Well, thank you, Harold, and it certainly is a pleasure to be here this morning just to hear all these stories, some of which give me a terrific number of ideas and others of which are just simply validating. So I am from the provider side. I'm actually a pediatrician by training and spent the first several decades of my working career thinking about the development of different individuals and the family systems that supported them. And I'm obviously now thinking about the development of different stakeholders and the health systems that support them. And lest I take any more time and we begin to think about who's stuck in the terrible twos, we'll just move on. So MaineGeneral Health, as Frank has already pointed out to you, is a system in central Maine. It is in the capital, and we do serve about 25% of our commercial spend is with the state of Maine as an employer. So as you've heard, the state of Maine has been leading and the State Employee Health Commission on this tiering and then steering. As Frank talked about those modest goals, I wondered, well, is he going to stay with all those modest goals? Because of course we fell off those modest goals. We were doing well in the beginning, but in the fall of 2008, we put an electronic medical record in our inpatient area, and we lost an automatic function, which was to give flu and pneumovax vaccines. Now, we picked that up. We put it in mid-September. By the time we had a full month of data at the end of November, we picked up that we had missed 79 immunizations for individuals with congestive heart failure and acute myocardial infarctions, but that was too late. So a year later, we fell off on the core measures and we were no longer preferred. Well, I just thought I'd go over and talk to those State Employee Health Commission people and explain the greater good of putting an electronic medical record in, and of course they would understand. They didn't. They were like, you missed, you didn't make it, you're off. And we know it's hard, you're right here in our capital. We estimate that we lost about $750,000 when elective procedures didn't come to our hospital. Probably worse was reputational loss. So what you can hear about that is it got our senior leaders at MaineGeneral's attention. So when we were looking ahead, we gained our preferred provider status back in mid-July, but we knew because of this HCAHPS data that we were going to lose it again, because as the state continued to expand, first it's quality, now it's going to be patient satisfaction, we're going to fall off in January of 2011. Along comes Elizabeth Mitchell. Elizabeth Mitchell comes to visit our system and talk with the CEO and I about what are all the things you're doing, and we talk about our concern that we're going to fall off. And she suggests maybe she can talk with Frank, and maybe we can talk with Frank. Now, one thing I want to talk about is, and some of you have talked about this, is the importance of relationships. It happens, I've known Frank for a long time. We worked on other initiatives. I was his pediatrician for his children. So he was willing to have a conversation. And we did go, but it was important that I had the chair of our board, the CEO of our system, the CFO of our system, as well as our leadership to come in front of the State Employee Health Commission in January 2011 and said, we want to do a partnership, we want to work on the triple aim, and we'll put some money on the table. So what the State Employee Health Commission did was they did not make us a preferred provider. That would have been too far. But they allowed us to be in a separate category. We're not preferred provider, but there wouldn't be any penalty. And we began our work in our partnership in January 2011 and have continued since that time. And as he has already pointed out to you, they have now added cost, and we have increased our risk contracting, and I'll say a few things about that. So this is a partnership. We do have equal representation from our own group, and frankly, it was fascinating. We have a CEO of a system level, we have a CEO in the hospital level, as well as board people and so forth. They all wanted to be on this steering committee. Now, we have a primary care physician and a radiologist as well as a community member, a board member, and the State Employee Health Commission has an equal number It is facilitated and prodded by the Maine Health Management Coalition, and it has continued to do its work now over 3 years. So some of the things are not unusual to you. We are involved with the triple aim, which are included in this, but it's also about changing health behaviors and engaging with those who are insured by the state, and it is very much about being transparent. In the first year, you're going to hear a bit from Mike about data, and I will tell you that we have just begun, now 3 years into this, to get some data to really help us move this process along. We did center on increasing access to primary care. We did increase bringing patients into our both our system and our practice level. We continue to work on the quality work. And in the beginning, in efficiencies, we worked on data around reducing ED utilization and readmissions. With there's 25 primary care practices within our system, we didn't go to them and say, we want you to reduce the ED visits for the state of Maine insureds. We talked about reducing ED visits overall. So though the state of Maine insureds only are about 8,000 of the 110,000 lives our primary care affect, we are actually doing this work across the system. You can't ask primary care to concentrate on any one population. So in this past year, because the state was being asked by the governor to have no increase in medical costs from one year to the next, none. They had to come back around to us as providers and say, this is what we're up against, you have to help. Some of the systems went and said to the state, well, we'll give you an increased discount. We decided that that wasn't the right way to go for us to move this system. We said we'll begin to concentrate on a PM-PM, and we'll meet you on a PM-PM. Now, we did that last July, a year ago July, with no data. I have to tell you, I have a senior management group who's willing to move forward and say this is the right thing to do. We need this data. We're gonna settle on where that number is, but we will go flat to the year before. And so we have now agreed that we would be flat FY13 to FY12. Yesterday was the first time I began to see some data on how well we're doing in the first quarter, and it's kind of like looking at the first time you do your taxes. It looks really good right now, but it's too early. It's only the first quarter of the year. We're below target right at the moment, but we're still putting away $1 million this year, and we will pay the state $1 million if we don't hit this target. So we have focused our system. $1 million is quite helpful. This is this vision I often give for our own system in terms of what are we doing. We have the payers across the top. This is a self-insured commercial payer. We have got to have a common reimbursement methodology to move our clinical system and pay attention to the varying populations that we're caring for, applying right care plans to those different groups. I will tell you, Maine is lucky. We have two health improvement groups, both the coalition, but Quality Counts, which is helping us move our primary care. Of the 25 primary care practices, we have 10 in a learning collaborative across with Lisa Letourneau's Quality Counts group. So this is, all of us were asked to add slides. Harold had us add slides, and this was mine. So yes, the state is working on benefit design to match with our clinical redesign. We have predominantly been working on primary care and complex care management. But even as we begin to do payment reform, bringing advanced payment and PMs into our system, we employ 70% of the physicians. And he has exhorted me and exhorted my group publicly that if you don't change your physician compensation, it is all for naught. So even though we have 10 to 20% of our physician compensation in quality and coordination, it needs to be more because they still perceive their compensation as productivity-based. So we are in the midst right now of a revamping of our physician compensation as the payment beneath the payment. That good? Good. So I think I've brought most of this forward. You've heard it from others. We're very lucky to have the kind of partnership we have between an employer like the state of Maine and ourselves. Frank did a wonderful job leading it. There's another woman now, Lori Williamson, who's picked up the reins, and we continue on with a trusting but at times tense relationship. It's very important to have a neutral coordinator. There are times when both of us needed to be prodded, and that was helpful. I don't need to tell you about data. This room understands the importance of data. It's important to get the employees engaged, and it's very hard to do this with just one payer. You need to have a larger group. So thank you very much.